Hello, my name is Patrick Jaramillo, and today I am going to be talking about intraoperative cholangiography. So, before we get into intraoperative cholangiography, I first wanted to talk about a pathology for the reasons of having a IOC. So the pathology that I chose is gallstones. Another name for gallstones is cholithiasis. And basically what this is it's hardening deposits of digestive fluid that can form in your gallbladder. There are several types of gallstones, but the three most common types are cholesterol gallstones, black pigment gallstones, and brown pigment gallstones. 90% of gallstones are cholesterol gallstones, and each stone has a unique set of risk factors. Some risk factors for the development of cholesterol gallstones could be obesity, age, female gender, pregnancy, genetics, rapid weight loss, and also certain medications. Patients with Crohn's disease and those with ileum disease are not able to reabsorb bile salts, and this could also increase your risk of developing gallstones. Cholithias results when stones obstruct the cystic duct, bile ducts, or both. Temporary obstruction of the cystic duct. This is when a large stone lodges in the cystic duct before the duct dilates and the stone returns to the gallbladder. This will result in biliary pain, which is usually short-lived. Another name for this is cholithiasis. A more persistent obstruction of cystic duct, as when a large stone gets permanently lodged in the neck of the gallbladder. This could lead to acute cholecystis. Sometimes a gallstone may get passed through the cystic gut and gets lodged and impacts the common bile duct, and this causes obstruction and jaundice. This complication is known as cholecystolithiasis. If gallstones pass through the cystic duct, common bile duct, and get dislodged at the ampulla of the distal portion of the bile duct, acute gallstone pancreatitis may result from backing up of fluid and increase the pressure in the pancreatic ducts. Occasionally, large gallstones do peripherate, and the gallbladder wall creates a fistula between the gallbladder and small or large bowel, producing bowel obstruction or ileus. Now, let's talk about the morbidity of gallstones. Gallstones are actually quite common here in the United States. Approximately 6% of men and 9% of women do develop gallstones. That's roughly about 25 million people here in the United States. The highest prevalence of cholithiasis arises in Native American populations, and gallstones are not as common in Africa or Asia. So IOC, also known as intraoperative cholangiography, is most likely done after the removal of the gallbladder. The reason why it's used after the removal of the gallbladder is for the surgeon to look to see if there's no gallstones left, or to see if there's anything obstructing the bile ducts. Having an IOC has a success rate of 90%, and if there is a common bile duct stone still left, the IOC will detect it. The accuracy of an IOC finding a stone is usually between 92 to about 99%. So now we have our indications. So these are indications as to reasons why you might have an IOC. Like I said, IOC is to help identify any bile duct stones, clarify biliary anatomy, and to help prevent any injuries to the bile duct. Some indications could be a laparoscopic colectomy, which is the removal of the gallbladder, and this comes with having jaundice or a history of jaundice, history of pancreatitis, particularly related to gallstone pancreatitis, elevated liver function tests, a common bile duct that is larger than 5 to 7 millimeters in diameter, a cystic duct larger than 3 millimeters in diameter, multiple small gallbladder stones, unclear anatomy, common bile duct stones visualized on preoperative ultrasound, possible bile duct injury or leak, and a short cystic duct. So IOC is an image of your bile ducts after removal of the gallbladder, like I said before, and these are indications as to why you would have one. One contradiction for not having an IOC would probably be if the patient is pregnant, because during the IOC we are using a C-arm, and the C-arm is using radiation. So this is something that the patient would have to talk to with their doctor to determine if the benefits do outweigh the risk. If an IOC cannot be performed, the alternative imaging modality that could be used could be a laparoscopic ultrasound. A laparoscopic ultrasound is able to look at the common bile duct and is able to evaluate if any stones are located as well. So patient preparation. So there's no specific preparations for having an IOC, but like I said before, IOCs are always done after a patient has their gallbladder removed. So there are preparations for when the patient is having a colostomy. So those preparations are going to be, the patient is going to have to talk to their doctor to see if their health is okay for surgery. The patient is told the risk and the benefits and will also have to sign a consent form. The doctor will tell the patient to not drink or eat, and the time is dependent on what time the surgery is. Certain medications should not be taken, and your doctor will be the one that you should talk to about that. Because there are certain medications that shouldn't be taken before the exam. What kind of medications that could affect it are blood thinners, supplements, and anything that affects the immune systems. But there are some medications that are safe to use before you do have one of these exams. Lastly, after the procedure is all done, the patient will need a driver to help take them home if the patient is okay to go home. And they also need someone to stay overnight to watch them after. So major equipment. So here on this slide I have a image of a C-arm, and you could see the monitor as well. This is basically how the X-ray tech is going to be able to take the image, and the image will show up right after. So IOC can be performed with limited equipment, and it needs several different catheters. It depends solely based on the surgeon. So many of the current IOC catheters and canals have a kit, and within this kit are all equipment needed to be able to perform an IOC and a colostomy. So in this kit it has a catheter or a canal, a syringe, introducer, needle, sheath, and a 3-way stopcock. Additional equipment may be needed, such as a clip applier, depending on the catheter being used in cases where the catheter needs to be secured in the cystic duct, as most surgeons use a clip applier during laparoscopic colostomy. This is often available. Contrast is also needed to perform an IOC, and the type of dye is based on the institution protocols. As the IOC involves radiation exposure, surgeons and operating room personnel should have protection from either using a lead apron, they should have a thyroid shield, and they should also have their dosimetry badges outside of their lead apron. And like I said, along with this, we do have the C-arm. Alright, so for the procedure, a clip is placed at the cystic duct, and this helps prevent flow of bile from the gallbladder or contrast into the gallbladder during the IOC. A small incision is made at the anterior surface of the cystic duct just below the clip and can be confirmed by the presence of bile. A small stab incision is made at the right upper quadrant, and a needle of guiding sheath is advanced pre-continuously into an abdomen angled towards the cystic ductotomy. At this time, a cholangiogram catheter of the surgeon's choice can be advanced into the cystic ductometry and secured with a clip, balloon, cystic duct holding device, or umbrella mechanism. Once the cholangio catheter is secured in place, the mobile C-arm will be covered in a sterile drape and positioned over the right upper quadrant of the patient. The bed, which should be positioned and able to accommodate a C-arm, can be adjusted to have the patient in a Trundle-Bird position and slightly to the right, which may facilitate placement of the C-arm. Respirations can be held after discussion with the anesthesiologist to obtain an image. So looking at the images that I have here on this slide, if you look at the one to the left, case 1, this is a normal IOC, so this has nothing wrong with it. This is what you want them to look like. And then if you look at the other image of case 2, if you see the white arrow at the bottom, it's pointing to a stone that is blocking the way. So contrast media, like I said, contrast media is used during this examination, but the amount and the type of contrast used is dependent at each site and also the surgeon. The purpose of contrast media is to help visualize if there is any blockage within the ducts, and what this could do is it could indicate if a stone is present. So filming, like I said before, the patient is in a Trundle-Bird position. The C-arm will be positioned over the gallbladder within the right upper quadrant to include the bile ducts. Also, if you're unable to put the patient in a Trundle-Bird position and they are supine, it's recommended that you do angle the C-arm about 15 degrees because you want to get the gallbladder away from the spine. And post-procedural care. So after a patient has completed a colostomy and IOC, the patient usually can go home after the surgery or they could stay in the hospital overnight. It's important that the patient does drink a lot of fluids after the procedure, and it's common to experience a bit of pain in the area of the surgery. The doctor could recommend any medication to help with the pain and also tell you to ice the area after. Complications, there's no complications with having an IOC, rather than the complications that come with having the gallbladder removed. Most of the complications can be bleeding, infection, blood clots, heart problems, and a possible chance of having a hernia. So with that, I am all done with talking about my topic. I hope you guys enjoyed this. I do have a couple of questions for you guys at the end. I'm probably going to do about 20 seconds for each slide, and then once you're all done, I will have the answers at the end. Alright? So for question 1, gallstones can be found in approximately what percentage of the United States? Question 2. What are indications to have an IOC during a laparoscopic colostomy? Number 1 is history of jaundice, history of pancreatitis, and 3 gallstones. Question 3. Where should the C-arm be positioned to help obtain an image of the gallbladder? Question 4. True or false? The 3 most common types of gallstones are cholesterol gallstones, black pigment gallstones, and white pigment gallstones. And question 5 is a couple of labelings. There's only 4, so A, B, C, and D. Alright, here's the answers, and here's my references. Thank you.